disappear, but adults with anxiety disorders report feeling anxious as children. I've always been this way. Prevalence 12 to 20% of children and adolescents would be diagnosed with anxiety disorder, school phobia, school refusal, two types, separation anxiety, worry about parental or personal safety when at school, fear of school, specific aspect of school environment, given example academic failure or school phobia, begins later in childhood, more severe and pervasive avoidance, social phobia, extreme shyness and withdrawal, may exhibit selective mutism, refusal to speak in unfamiliar social setting, prevalence 1% of children and adolescents, etiology, overestimation of threat, underestimation of coping ability, poor social skills, PTSD, exposure to trauma, chronic physical or sexual abuse, community violence, natural disasters, symptom categories, flashbacks, nightmares, intrusive thoughts, avoidance, hyperarousal and vigilance, etiology, pre-existing anxiety, family stress and coping styles, parental response to trauma, OCD, prevalence 1 to 4%, symptoms similar to those in adults, most common obsessions, contamination from dirt and germs, aggression, thoughts about sex and religion, more common in adolescents, OCD more common in boys than girls. Etiology of anxiety disorders, genetics, heritability estimates from 29 to 50%. Genetics play a role or play a stronger role in separation anxiety in context of more negative life events. Parenting plays a small role in anxiety disorders, only 4% of variance. Emotion regulation and attachment problems also play a role. Perception of lack of acceptance by peers, a factor in social phobia. Risk factors or for PTSD include family stress and coping style, past experience with trauma, treatment of anxiety disorders in childhood and adolescence, exposure to feared object, reward approach behavior. CBT Kendall's coping cat program shows to be effective in 2 randomized clinical trials for kids between 7 and 13 years old. Cognitive restructuring, develop new ways to think about feats, psychoeducation, modeling and exposure, skills training, relapse prevention, family involved in treatment. Learning disability, evidence of inadequate development in a specific area of academic, language, speech, or motor skills. Give an example, arithmetic or reading, not due to mental retardation, autism, physical disorder, or lack of educational opportunity. Individual, usually average or above average intelligence. Learning disability, DSM-IV-TR categories, learning disorders, communication disorders, motor skills disorder, often identified and treated in school. Reading disorders, more common in boys. Etiology and learning disabilities, dyslexia. Genetic factors. Evidence from family and twin studies. Genes are those associated with typical reading abilities, generalist genes, problems in language processing, speech perception, analysis of sounds and their relationship to printed words, difficulty recognizing rhyme and alliteration, problems naming familiar objects rapidly, delays learning syntactic rules, deficient phonological awareness, inadequate left temporoparietal occipital activation, treatment and learning disabilities, reading and writing disorders, multisensory instruction in listening, speaking and writing skills, readiness skills in younger children as preparation for learning to read, phonics instruction, communication disorders, fast forward involves computer games and audio tapes that slow speech sounds, mental retardation, significantly below average intellectual functioning, IQ less than 70, deficits in adaptive functioning, self-care, communication, home living, decision making, onset before age 18. Most professionals focus on strengths of individual to assess ability to function. Intellectual disability, now preferred term over mental retardation. Etiology of mental retardation, neurological factors. Down syndrome, chromosomal trisomy, 47 instead of 46 chromosomes, Fragile X syndrome, mutation in the fMRI gene on the X chromosome, recessive gene disease, phenylketonuria, PKU, maternal infectious disease, especially during first trimester, HIV, rubella, syphilis, brain injuries from falls or auto accidents, lead or mercury poisoning. Treatment of mental retardation, residential treatment, small to medium size, community residences, behavioral treatments, language, social and motor skills training, method of successive approximation to teach basic self-care skills in severely retarded. Give an example: holding a spoon, toileting, applied behavioral analysis, cognitive treatments, problem-solving strategies, computer-assisted instruction. Pervasive developmental disorder, autistic disorder, Kanner's 1943, autistic aloneness. Impairments in social interactions, at least two of the following: deficient use of nonverbal behaviors, poorly developed peer relationships, lack of social or emotional reciprocity. Impairments in communication, at least one of the following: delay in or total lack of spoken language, difficulty initiating or sustaining conversation, repetitious or idiosyncratic language, echolalia, pronoun reversal, lack of developmentally appropriate play, pervasive developmental disorder, autistic disorder, repetitious or stereotype behaviors, at least one of the following: abnormal preoccupation with objects, ritualized behaviors, body rocking, hand flapping, stereotype mannerisms, abnormal preoccupation with parts of an object, begins before age 3, autistic disorder. A study with adults found that people with autism pay attention to different parts of faces than do people without autism. Spezio et al. 2007. Adults with autism focus their gaze mostly on the mouth region and almost entirely neglected the eye region. This neglect likely contributes to difficulties in perceiving emotion in other people. Etiology of autistic disorder. Bettelheim's psychoanalytic theory, 1967. Rejecting and unresponsive parents, child withdraws into his own world. Theory unsupported by empirical data. Genetic factors, twin study, 60 to 91% concordance rates. Genetic flaw, deletion on chromosome 16. Etiology of autistic disorder. Neurobiological factors, brain size. Although normal size of birth, brains of autistic adults and children are larger than normal. Pruning of neurons may not be occurring. Overgrown areas include the frontal temporal and cerebellar, which have been linked with language, social, and emotional functions. Treatment of autistic disorder. Intensive operant conditioning, Lovas 1987. Parent training and education. Pivotal response treatment, Kogel et al. 2003. Focus on increasing child's motivation and responsiveness rather than discrete behaviors. Joint attention intervention and symbolic play used to improve attention and expressive skills. Medication most common used: haloperidol, Haldol, antipsychotic, reduces aggression and stereotype motor behavior, does not improve language and interpersonal relationships. Asperger's disorder, less severe form of autism, language and intelligence intact, poor social relationships, and rigid stereotype behaviors recently recognized more in adult population. Late life and neurocognitive disorders. Neurocognitive disorders in late life. Most elderly do not have cognitive disorders. Prevalence has decreased over last 15 years. Dementia, a deterioration of cognitive function. Delirium, a state of mental confusion. Dementia, deterioration of cognitive function. Impaired social and occupational functioning. Progresses over time. Begins with difficulty remembering recent events. Deficits can be detected before impairment becomes obvious. Mild cognitive impairment develops slowly. DSM-5 proposes two categories differentiated by ability to live independently. Mild neurocognitive disorder, mild cognitive impairment. Major neurocognitive disorder, dementia. Table 14.3. Proposed DSM-5 neurocognitive disorders, delirium. Neurocognitive disorder, specify mild or major. Neurocognitive disorder associated with Alzheimer's disease. Neurocognitive disorder associated with frontotemporal labor degeneration. Neurocognitive disorder associated with vascular disease. Neurocognitive disorder associated with traumatic brain injury. Neurocognitive disorder associated with Lewy body disease. Neurocognitive disorder associated with Parkinson's disease. Neurocognitive disorder associated with HIV infection. neurocognitive disorder associated with substance abuse, neurocognitive disorder associated with Huntington's disease, neurocognitive disorder associated with prion disease, other specified neurocognitive disorder. Table 14.3. Credits 2012, John Wiley and Sons Incorporations, all rights reserved. Proposed DSM-5, minor neurocognitive disorders, minor cognitive decline from previous levels in one or more domains based on both of the following. Concerns of the patient, a close other, or a clinician. Neurocognitive performance below appropriate norms, in other words, between the 3rd and 16th percentile on formal testing or equivalent clinical evaluation. The cognitive deficits do not interfere with dependence. In other words, tasks such as paying bills or managing medications, even though greater effort, compensatory strategies, or accommodation may be required to maintain independence. The cognitive deficits do not occur exclusively in the context of a delirium and are not due to another psychological disorder. Proposed DSM-5 major neurocognitive disorders. Evidence of significant cognitive decline from previous levels in one or more domains based on both of the following. Concerns of the patient, a close other, or a clinician. Neurocognitive performance below the 3rd percentile on formal testing or equivalent clinical evaluation. The cognitive deficits interfere with independence. The cognitive deficits do not occur exclusively in the context of a delirium and are not due to another psychological disorder. Alzheimer's disease, described by Alois Alzheimer in 1906, irreversible brain tissue deterioration. Death usually occurs within 12 years. Usually begins with difficulty remembering recent events, learning new material, irritability. As disease progresses, language problems intensify, including word finding, disorientation, time, place, and identity confusion, agitation, depression, brain changes in Alzheimer's disease. Plagues. B. Amyloid protein deposits, primarily found in frontal cortex. Neurofibrillary tangles. Protein filaments composed of tau in axons of neurons, primarily found in hippocampus, measured using PET scans. Plaques most dense in frontal cortex, tangles most dense in hippocampus, loss of synapses for acetylcholinergic ACH and glutaminergic neurons. As neurons die, atrophy of cerebral and entorhinal corticals and hippocampus, enlargement of ventricles. Genetic factors, heritability 79%, APOE4 allele gene on chromosome 19 having 1E4 allele increases risk by 20%, having 2E4 alleles increases risk substantially more. Related to overproduction of beta amyloid plaques, loss of neurons in the hippocampus, and low glucose metabolism in cerebral cortex. Environmental factors, smoking, being single, low social support, and depression related to greater risk of developing Alzheimer's. Mediterranean diet, exercise education, and cognitive engagement predict a lower risk. Give an example: solving crossword puzzles, reading the newspaper daily. Cognitive reserve, use alternative brain networks to compensate for disease. Frontotemporal dementia, loss of neurons in frontal and temporal lobes. Memory not severely disrupted, impairment of executive functions, planning, problem-solving, goal-directed behavior. Difficulty recognizing and regulating emotion. Much more profound impact than Alzheimer's, caused by multiple genetic pathways. Pick's disease, high levels of tau proteins. Vascular dementia, typically results from stroke, cardiovascular, clot forms, and impaired circulation. Cells die. Risk factors, smoking, high LDL cholesterol, high BP. Symptoms can vary greatly depending upon location of strokes. Dementia with Lewy bodies, DLB, 2 subtypes. With Parkinson's, no Parkinson's. Symptoms similar to Parkinson's and Alzheimer's diseases. Shuffling gait, loss of memory. Symptoms differ in that DLB patients have fluctuating cognitive symptoms, prominent visual hallucinations, intense dreams involving movement and vocalizing. Dementia's causes by diseases. and injury. Other medical issues: encephalitis, inflammation of brain tissue by viruses; meningitis, inflammation of covering membranes by bacteria; HIV, head traumas, brain tumors; nutritional deficits, B complex vitamins; prevention and treatment of dementia. Medications: no drug reverses Alzheimer's disease; some drugs produce slightly less decline. Cholinesterase inhibitors, drugs that prevent breakdown of acetylcholine; donepezil, Aricept, galantamine, Reminil; vitamin E, statins, and non-steroidal anti-inflammatory drugs have failed to find support. Preventive work focuses on processes involved in the creation of amyloid from its precursor protein, antidepressants for depression, antipsychotic medication for agitation, treatment of dementia, psychological treatments, supportive psychotherapy for family and patient, education about disease and care, cognitive interventions when disease is in early stages, labeling drawers, appliances, calendars, clocks, and strategically placed notes. Exercise has been associated with cognitive benefits. Music appears to reduce agitation and disruptive behavior. Delirium, clouded state of consciousness, extreme trouble focusing attention, disturbances in the sleep-wake cycle, fragmented thinking, speech is rambling and incoherent, disorientation, perceptual disturbances, memory impairments, mood swings. Secondary to underlying medical condition, detection of delirium, important but often missed, untreated. Further cognitive decline and mortality may occur beyond treating the underlying medical conditions. The most common treatment is a typical antipsychotic medication.